are a little bit late, but can I ask the speakers to come here? If the auditorium has some questions. About bone defect for Dr. Itoi. Yes, Philippe.
AG, thank you for this amazing presentation. Difficult to discuss everything because you give us many information that it's a huge and fantastic presentation. Just about this on track and off track, which is a very nice concept that I could understand for a normal range of motion for a non-athlete. I mean, not in static, but I would say in a normal motion during the daily activity. Don't you think that if we are talking about a throwing athlete with the speed, the fact that the motion is very fast and sometimes exaggerated, don't you think that an off-track could become on track with the flexibility, elasticity of the anterior capsule?
Thank you for your question. That's a very good point. Actually, we measured the glenoid tract by applying a certain amount of force, but of course it depends on the range of motion and also laxity of the joint. And right now, if the range of motion is larger, then the glenoid tract becomes narrow. If in a stiff shoulder, it's very wide, so no problem of engagement. So, 83%, 84%, that's just an average value measured in the young volunteers. But we need to know the precise assessment for each and every one of the patient. For that purpose, right now we're trying to measure the range of motion with the patient lying supine on the examination table and measure the external rotation with the arm in 90 degrees of abduction. And using this value, we made a kind of a chart. And okay, you have this range of motion, then your glenoid tract would be like this. So right now we are trying to make this chart. So that's a very good point. And as I said, 83%, 84%, that's just an average value.
I got a question also. You got a beautiful work study there. So on the last slides of your talk, you said if you got an off-track Hill-Sachs, then you got a glenoid defect more than 25%. You mentioned that you would do a Lauder J and maybe a remplissage. And that idea really, frightens me. In my mind, if you do a Lauder J, I think, as Gio said, it is always the conjoint tendon has a sling effect. For the sling effect, another is the compression of the lower one-third of the subscapularis, who play the main job for the stabilities. And that will change. As your study said, it even have a better stability than the intact shoulder. So that would change. The Lauder J would change the shoulder biomechanics already. And for that kind of patient, if you do a Lauder J anteriorly, and then you do a remplissage, that frightens me. So would you worry about that will change the whole biomechanics of the shoulder? I will be very careful to doing a remplissage with the Lauder J patient.
Yeah, actually, personally, I don't have any experience of doing both. Because when you do Lauder J for that type of patient, that's just enough. And if you perform Lauder J, there's always a conjoint tendon attached to the coracoid process. So that may prevent the overriding of the Hill-Sachs lesion on the coracoid process. So maybe it's not necessary. And in our series of 100 cases, there is no case with the off-track Hill-Sachs 25% glenoid defect. So do you have any experience with that?
Just from a technical point of view, how can you do an open Lauder J and a remplissage? So people who are doing arthroscopic Lauder J might be able to add a remplissage, but when you spend 3 hours doing an arthroscopic Lauder J, most of the time it's time to go home and you don't do any remplissage. So it's might be so. It's why remplissage is added to arthroscopic bank cart.
So if you perform the iliac bone graft, for example, that will create the perfect glenoid. but that may be large enough to cover the Hill-Sachs lesion. In that case, we have to do something to the bone grafting or something. Yes, yes. Yeah, so that's a theoretical thing, but I don't have any personal experience of that.
Yeah, so for instability, first time shoulder dislocation, any questions?
It's interesting to see that in all the series, there is about 15% of recurrence even after arthroscopic stabilization in first dislocation. Do you think it could be correlated to the fact that this patient, even after first dislocation, are off-track patients? You know what I mean?
The old data shows that recurrence rate after arthroscopic bangor repair is 49% by Gilles Walsh, but I think that's a technical thing. He used the I think that's a Kaspari technique, and that Morgan technique. So that's not an ideal procedure. So he abandoned doing that. But if I know he's a very good surgeon, so if he does arthroscopic bangor repair now, he should be able to present a very, very good data, I'm sure. So I think, yeah, but of course, the off-track could be one reason. But as I said, the real off-track is just 7%. So it's not a big percentage of the entire group of patients. I have one question to you, Philip. You said 15% of the patients for initial dislocation, you've done stabilization right after the dislocation, right?
15 cases.
Cases, yes. And what is the out of how many patients?
It took us 3 years to find out 15 patients.
Okay, but that's 100%, or what's the percentage of the you do the surgery out of?
Yeah. How many first-time dislocators you see for the 3 years?
Obviously, much more of this. Only 15 patients accepted to have a surgery for a first-time dislocation. Although, it's a 1/4.
I'm very glad to hear that because if we do the arthroscopic or open surgery after initial dislocation, as you said, it's a very good procedure. And I quite agree with you. There's no question. That's the best procedure to provide the stability of the shoulder. However, it's a surgical intervention. So if you do surgery to every and all the patient that you see after initial dislocation, that's definitely an overtreatment. Robinson from England, he calculated the number needed to treat in his JBJS paper, 2007. And the number needed to treat is a number of patients you need to do, for example, bangor repair, to save one patient out of how many? And for the general population, number needed to treat is 7. That means you have to do the surgery in 7 patients to save one patient from recurrent dislocation. But if you do the surgery for the active young patient, the number needed to treat would decrease down to 2.7. But still, 2.7 means close to 3. You have to do the surgery for 3 patients to save one patient out of recurrent dislocation. So definitely, if you do the surgery for all the initial dislocators, that's definitely an overtreatment. So we need to talk to the patient, the proper information, Of course, this is a very good treatment. But of course, there's a risk of something. And then if the patient really wants to have a stable shoulder, regardless of the procedures, then I think that's a good procedure. But if you do 100% of the initial dislocators operation, that's too much. That's what I want to say.
I totally agree. I totally agree. I said the high-level athletes, you have to fix them. The population, you have to give them the option. I think doing surgery on all the patient is an error. On the same time, just putting back the shoulders in a sling and go home, that's another error. You have to give the information to the patient or put him in this position.
Well, external rotator immobilization like this, we perform this about 10 to 15 degrees of external rotation. And after that, there are several studies, prospective studies showing the good outcome for the external rotation immobilization. But the other group showed negative data, like Liviag from Norway. But they said the compliant patient, their definition of compliance is more than 16 hours per day immobilization. That means 16 hours of immobilization, but 8 hours free. Does that make any sense? I don't think so. So I think, and there's a group from India. They use the casting, so it's 100%, 24 hours a day. And their result is very, very good. It's amazingly good, better than ours. So I think it's totally a compliance issue. And this position is not so comfortable for the patient. And for the students, I applied this for the medical students, and they said during the lecture, you hit the next student sitting next to you. So it's kind of a problem of this procedure. And it's still evolving right now. We're trying to add some abduction that may be better for the coaptation of the Bankert lesion. So I think we can show you some better data in the near future.
So this is a procedure just for Japanese, not for the Vikings, right?
But I've seen few acute ALPSA lesion, acute ALPSA. There's no way they can go back.
I'm not saying 100% of the patient is okay after this, but at least, doing the immobilization in a sling, this is nothing. Yeah, so if you prefer to do the conservative treatment, this is the way to go. That's what I want to say.
Just a question for Philippe. 15-year-old rugby player, recreational. He wants to play rugby, 2 dislocation in 6 months. No bone loss. What you do in France?
15?
15.
1-5?
1-5.
And rugby is a leisure player? Recreational?
Recreational.
15? We explain 100% rate of failure.
I know, but just technically. Because you said that some people in France, they do Latarjet for
No, I
this.
would do arthroscopic. First, I do
Arthroscopic,
arthroscopic. But there are some surgeons used to do Latarjet in first-time dislocation for. No. If there's heel sac lesions, I would try a balloon now. I would probably try a balloon. Although the growth plate is open. If the growth plate is open, it's another problem.
Good. For about posterior instability. For Jiang, any questions?
I have a question for the both speakers about the posterior instability and MDI. I have a big problem with the sulcus sign. Which anatomical structure are we testing when we do the sulcus sign?
When I do a sulcus sign, I always in a neutral rotation. Never do an internal. I rarely do an external. It's a neutral rotation. If you got a big sulcus sign in a neutral rotation, for me that will be inferior capsule, the pouch.
I think we are testing the interval and the capsule between the superior glenohumeral ligament, the coracohumeral ligament, and the medial glenohumeral ligament. And I think that the sulcus and external rotation, when you perform it before surgery, when you go to surgery, you find a very lax interval.
What's your idea?
I don't use sulcus
sign. We did the biomechanical study of a sulcus or intra-articular pressure, and the sulcus sign appears when there's a negative, very large negative pressure, and if you put the arm down, the negative value increases in proportion to the force. However, if the capsule is thin, if the volume is large, then the negative pressure was not so much created in that shoulder. That's why MDI patient has a sulcus or inferior subluxation during the rest. So.
trust more the Gagé side.
Okay, I think it's
For posterior instability, do you think that painful patient and patient who experience subluxation have the same disease that people who have posterior dislocation? Because in most of the papers, all the patients are put together. I'm not sure we can assess the posterior instability with the same technique. Do you think, for example, for people who have recurrency of real posterior dislocation, the Bankart and plication procedure are a good procedure for this patient?
So the question comes as the difference between how to treat a total dislocation and a subluxation.
Yeah.
As I said, I don't think a very classical, like a total dislocation with posterior Bankart is very common for posterior instability. If that's the case, I would believe a very promising result when you reconstruct the Bankart, posterior Bankart, with the plication of the capsule. And if trauma, those kind of instability were always caused by trauma or seizures. But most of the time we have micro traumas, repetitive, erosions. So I would think that you have to address all the pathologies, not only the posterior. Then you got to balance the whole thing, address the laxity. So it's a kind of comprehensive treatment.
okay. Halas for this morning. We will meet again here at 2:15. Okay, please.